I think we'll get going. So thank you all, and welcome to the special i3 session. It's called Unstoppable, and we're really here today exploring how technology is reshaping the IVF lab and fertility care. So experts here are going to discuss advances in clinical management, genetics, decision-making, and topics ranging from precision tools that are driving change and building trust through innovation and gamification. And then the role of algorithms in the future of pre-implantation genetic testing. So we'll have a real focused look on where IVF is headed, from the lab to the patient and through emerging technologies. So my name is Carol Loscher. I'm based in Dublin in Ireland, and I'd like to introduce my co-hosts. So first of all, we have Dani Wild. So Dani is a senior clinical embryologist from the UK from Complete Fertility, and she's working alongside Charissa, our other co-moderator. And Dani has a keen interest in innovative new technologies in IVF. And you may have seen her graphic works in recent publications, including the Green IVF paper and Jack Cohen's AI piece for the 25th anniversary of OrbiMO. So take a look. We also have Charissa Watchorn, who's the lab manager and senior embryologist at Complete Fertility Centre in the UK, which is part of the Versus Health Global Network. Charissa has recently led the development of their new state-of-the-art IVF laboratory, integrating the latest technologies to advance patient care and optimize clinical outcomes. And of course, more detailed bios are available on the i3 website.
Great. Thanks very much. To reciprocate, with a background in pharmacology and a PhD in genetics, Dr. Loscher entered the field of embryology and has gathered a wealth of experience within Ireland's leading fertility clinics and is laboratory manager at Therapy Fertility's new IVF laboratory in Ireland. She is dedicated to enhancing accessibility and affordability for patients. She also focuses on driving efficiency through technology and improving patient outcomes.
Thank you, everybody. So as you can see, today we're going to keep our bios really short. But if you do want to see sort of the more extensive resumes of the careers of the experts here tonight, these can be found on the i3 website. Also, just another reminder, please place your questions in the questions section on the portal, not in the chat function. But without further ado, I'll introduce our first speaker, with a talk kindly sponsored by Fertile AI. Professor Ariel Hourvitz is the head of IVF unit of Asaf Horev Medical Center and the director of the reproduction laboratory, Chaim Sheba Medical Center, Tel Hoshma, and full professor at the Shackler School of Medicine, Tel Aviv University, Israel. He is also Chief Medical Officer at Fertile AI, a company harnessing learning from lifetime of data, deploying precision technology to help doctors predict the day and dose for the best chance of pregnancy, while smoothing the workload for embryologists.
Thank you for this kind introduction. And in fact, as mentioned, today we will talk about AI and reproduction in the clinical practice. More precisely, how AI will change the way we practice medicine as an IVF specialist. So these are my conflicts of interest. And let's begin with AI. So the definition of AI, probably most of you know, is the ability of computers to mimic cognitive function and to solve problems and take decisions that are usually performed by human intelligence. I think that the best test to describe was already suggested in 1950 by Alan Turing, known as the Turing test. And what he said is that a human judge, also called the interrogator, asks questions for a machine and a human being to answer sitting in another room. If the judge cannot distinguish between the responses from the machine and the man he's talking with, then it will be recognized as AI. So this is what we are going to talk about. And there are two more nice citations that I think are related to what we are going to talk, is that the value from IT emerge only when people, processes, and organizational structures change. And I think that really the most profound technologies are those that disappear. They weave themselves in the fabric of everyday life until they are indistinguishable from it. So let's keep it in mind. And going back to AI in reproduction, I think that the advantages are also well known to most of you. AI can learn and analyze big data and very complex patterns. This is its big advantage. It can make decision process reproducible and repeatable. And unlike human, whose decision can be influenced by emotions, fatigue, or unconscious biases, AI operates with objectivity and fairness. It is rapid, accurate, and precise. Like everything, it has also some limitations and challenges. I think that one of the big problems of AI is the data quality. We know that there is lack of standardization of the structured EMRs. There are biases in the data used. The data privacy is an issue. There's lack of regulation. And always data sharing obstacles is also a challenge that we have to meet dealing with acquiring data. So we have always to overcome this data quality and to be aware of. The second thing is the loss of expertise. There was recently an article published in JAMA about it, and the fear of over-reliance on AI might degrade clinicians and embryologists' decision-making skills, and we will lose it. And other issues are the black box versus explainable AI. We are all afraid of something that we don't fully understand, and the black box is an issue we have to deal with. Finally, the lack of empathy and personal touch will cause this system not to replace the clinical judgments of the providers, but support it, offering the opportunity to combine experience with evidence-based decision-making and AI, to use it as a decision support. So these are some of the processes that AI is already having some applications at the different step of our practice. It might be involved in outcome prediction, initial dosage, treatment decision during the stimulation, when to trigger, ovulation prediction, and workload balancing. Of course, I cannot go over all of it, but I will concentrate today on the three last ones, the trigger, the ovulation prediction, and workload balancing, and trying to show you how can we use it in the day-to-day practice. So let's begin with the triggering. Defining the optimal time to trigger a patient is always a highly controversial and subjective topic with multiple criteria and many different practices. We're all aware of the difference we find between European or the US approach. And we would like to have what we expect, in fact, to have from introducing the machine learning is to standardize and have a more data-driven approach, resulting at the end in improved oocyte, M2, and embryo yields, and hopefully also pregnancy rates. So this is an article we published in 2023 about the use of AI to help us decide when to trigger. The aim of the study was to develop a machine learning algorithm for choosing the optimal day for maximizing the number of M2 oocytes retrieved during an antagonist protocol cycle. In fact, we asked the machine at the first step to predict how many oocytes will we have if we trigger today, tomorrow, or in 2 days. For that end, the data set we used included more than 10,000 cycles from 50 different practices that were split into 3 groups, like we always do with the AI. So we have a train set, a validation, and finally a test set to test our results. Here you can see the accuracy of the model. Here is on the x-axis is the actual number of M2, and on the y, the predicted number of M2 oocytes by the model. As you can see, the R-square was quite good with 0.8 on the day if we trigger today, when the algorithm say to trigger tomorrow or in 2 days, of course, it went a little bit down, but still was quite good with 0.7 R square and a mean absolute error of 2.7 when predicting what will happen if I trigger in 2 days. So this was the accuracy, which is, as I said, quite good. But as physician, the important outcome, as I said, is the real number of the oocytes. Or does the machine will result to give us at the end more oocytes? To analyze this on a retrospective data set, we use a test that we split our data into 2 groups. The first one was the group that the physician did what the machine recommended. We called it the concordant group. So, for example, if the machine recommended to trigger today or tomorrow, and the physician, what he did, he triggered today, so it's a concordant, it's part of the concordant cycle. It's a concordant cycle. However, if the machine of the same cycle say trigger tomorrow, but the physician trigger today, it will be discordant cycle. So we analyze all these cycles, and here you can see the results comparing the concordant and the discordant cycles. Altogether, there was an agreement of only 25% between the machine and the physician. In those cases, there was an average of 12.3 oocytes retrieved. When we looked at the discordant group, what the machine say, no, look, triggered mostly later than triggered before. So the machine would trigger a day or 2 later, then the number of oocytes in this group was only 8.7. So there was a difference of an additional 3.6 oocytes when the physician did what the machine was suggesting. And this resulted, and not surprisingly, with almost 1 more blastocyst. So on the clinical side, this showed the advantage of the machine over the physician. I have to say that it is a retrospective study, and we are currently trying to, we are beginning a prospective study on this subject. Currently, we also upgraded our algorithm, and we are now developed a new algorithm that is based on 3 large clinics in 3 continents, in Europe, the United States, and Asia. We have quite similar results. And another advantage of the new algorithm that it is good for all stimulation protocols, including the long agonist, the flare-up, PPOS, modified natural, and so on. How it looks in the daily practice. So here you can see, well, you all know the stimulation chart. And this is on day 8 of the cycle. You can see this is a real case. Of course, the names are not real, but it's a real case. And at that time, she had 14 and 13 and 12 follicle size. The algorithm doesn't trigger on those days, so he identified it as an anomaly. You can see the red point, and he suggests in any case to come in 2 days and not trigger, of course, today or tomorrow. So women coming later in 2 days later, and these are the results, 17, 15, 13, these are the blood tests. Again, you can see that he's expecting between around 10, but is suggesting again to come in 2 more days. These are the predicted M2 oocytes. So the patient is coming 2 days later. Now we have 20, 20, 20, 19, 19, and so on. At that time, the algorithm is expecting, if you trigger today or tomorrow, quite a similar, not a big difference of number of oocytes, of M2 oocytes. But if you wait another day, so in 2 days, there will be less. So now you have the choice to trigger either today or tomorrow. And I can tell you that this was a good case because these women had, in fact, 16 M2 oocytes. So this is how it looks in the practice. Another algorithm I want to show you is related to ovulation prediction. as you all know, the ability to predict ovulation, it's important for frozen embryo transfer in natural cycle. It's also it can be helpful for modified natural and of course for intrauterine insemination and time intercourse. I think that the big advantage probably of using ovulation prediction is for what we call assisted selective modified natural frozen embryo transfer, which means that the use of such an algorithm will enable us to deal with scheduling of natural cycle. I mean that, for example, if the clinic is closed on Sunday and there is a reduced staff on Saturday, in those cases, the algorithm predict ovulation to be on those days. It will suggest 1 or 2 days ahead to trigger it and trigger only those cycles that we want to trigger earlier to prevent them from falling on the weekend. So this will be, and we have a nice work on it. But let me show you how it works with the I'm sorry. Sorry. Yeah. Yeah. So this was also published last year in scientific reports. And you can see that it was tested again on more than 1,000 cycles, divided into the different test sets. To test the accuracy of the prediction, we used 2 test sets. One was 500 cycles, that 20% of them that were reviewed by 3 expert opinion to decide when the ovulation occurred, and we tested according to the expert decision, the correlation with the expert. Another interesting test that we used was what we call the documented ovulation. These are the one that we had the follicular, that in the ultrasound we could show the follicular disappearance. So the follicle today was present and the next day was absent. And we had a documented LH surge with more than 17 IU at the day before ovulation. So it was a very classical documented ovulation test set. And we compare the machine decision versus, this is the prediction of the machine, versus the actual decision. And we were able to obtain a total accuracy of about 94% of the algorithm compared to the expert test set, and about the same 93% compared to the documented ovulation test set. So this was really, again, a very nice accuracy. But again, we wanted to see how it's implied in the clinical part. And for that, we use the same method of concordant and discordant, going over all our cycles and dividing them by the cycle that the transfer was performed according to the machine prediction, and those that the transfer was not in accordance, was done in another day that the machine suggested. And when we compare those concordant cycles with the discordant ones, again, there was a very significant increase in the pregnancy rate. You can see here the difference of the pregnancy rate of those 2 groups. And again, how it looks in the real life. So again, you can see the chart. This is a woman coming here. You can see the blood test, and this is just with the blood test. You can add also the ultrasound, but for predicting ovulation, it's not very important. It's important to see, of course, the endometrial thickness and so on. But here we begin on the 8th day of the cycle. The prediction of the algorithm at that time is that it will be after at least from the 4th day or more. So we bring her again 4 days later. And this is what we see. Again, this is the blood test, estrogen. You can see the progesterone and LH. At that time, the algorithm predicts that it can be either in 2 or 3 days. He's not sure, but he's saying that there will be 80% that it will be in those days. But to be sure which of those days, we bring her one more time, and then you can see the estradiol is now 1,000, the LH, the progesterone is 3.1, and the LH is 47. So we know, and the algorithms predict correctly that the ovulation will occur the next day with a certainty of 85%. So this is for ovulation prediction. And I want to finish with the workload balancing algorithm. This is the problem that we all face, the big variability of the IVF cycles in all clinics, especially those with a big volume. And here you can see the fact that having peaks of 20 or more on some days and less than 10 on others is a big issue for both the lab and the OR and the personnel and so on. So we will be happy if those variation will be less. And for that, this is the article we published also last year in Fertility and Sterility on this. And the thing, we took advantage of the trigger algorithm. As you saw in the trigger, in some cases, in 65%, it was suggesting only 1 day for trigger. But on more than a third of the cycles, there was no big difference if you trigger today or tomorrow and in 2 days. Sorry, or in 2 days. So in those cases, we were able to use this suggestion to try to balance the cycles. And here you can see that after the balancing model was introduced, and we were able, in those cases that without any harm to the patient, defer or make it earlier, the trigger, you can see here visually how we were able to have almost half the standard deviation, reducing it from 6.4 to 3.4, and you can see it graphically. And the range decreased from 2 to 28 to 9 to 22. So we really minimize the standard deviation. And if we can look at it in another way, if a clinic is able to do, let's say it was doing up to 28 cycles, so we were able, due to the decrease in the standard deviation, we were able to have an average of 18.6 cycles per day compared to before balancing 14%, which means an increase of about 27% in the work capacity of this clinic. So we can really use this optimizing the workload balancing to increase the IVF and retrievals activity with the same clinic's capacity, plan staffing in the IVF lab, and improve the use of our resources and personnel. So I just show you several of the examples that already there are application to help us, and they are also in outcome prediction. You know, all those calculators, many of them based on AI, the initial dosage prediction, and so on. And I really believe that in a short time, AI will be implicated in many of those processes with the aim of a full management of the IVF cycles, hopefully not in a long time. And, oh, sorry. So I will end with this citation from Antonio Di Leva that I like to end my presentation, saying that machines will not replace physicians, but physicians using AI will soon replace those not using it. And I have to say that as time advances, and I'm beginning to feel that it's not completely true. I'm not sure anymore that we will not be replaced. And at least I think that it will drastically change our jobs and the way we practice. And with this note, I want to thank all our partners and Fertile AI teams, and to thank you for listening. Thank you very much.
Super. Thank you so much, Ariel. That was a fascinating talk. Very interesting. I think we can probably all see how that technology can have a huge impact on the workload, I guess, in the lab and trying to balance that. So it sounds fantastic. I'm wondering if you feel like this may if it's used appropriately, could it reduce the number of potentially egg collections on a weekend? And where do you foresee the main advantages in balancing workload?
Yeah, as I said, one of the interesting application is really to deal with those things of the closure, the weekends, of triggering, because it's just a question of setup. How I will set up the algorithm to ask him not to have pickups on Saturday or on Sundays, to combine it with deferring the natural cycle transfers, as I said, and this is things that the algorithm will do it much better probably that we are doing, although we're all trying to do it, of course.
Of course. And I guess it's also some sense of security that we feel we're doing the best for the patient at the same time, not just to suit
exactly it's
ourselves,
objective.
Yeah,
it's objective. It's a good tool to deal with different physicians when you are running a clinic, and you have to deal with many physicians that everybody doesn't want to, and having an objective tool, it's always an advantage.
Yeah, absolutely. Standardization. Now, that's fantastic. And Ariel, will come back to you at the end for the question and answer section. So again, everyone, if they have questions, put them in the Q&A. And now we'll move on to our next speaker. So I would like to introduce Professor Darren Griffin. Darren is a professor in genetics, specializing in reproduction and evolution with special reference to chromosomal changes. He holds a position at UCL Royal Vet College in Kent University and Kasetsart University in Thailand, and has published around 400 papers and supervised about 50 PhDs. So welcome, Darren. It's very lovely to have you.
Thank you so much. Hopefully you can hear me okay, and hopefully you can see my slides. So thanks very much for the invitation, particularly thanks to Giles. All our thoughts go out to him at the moment. I know his other half has just come out of surgery at the moment, so please join me in wishing him all the very best. Now, this particular study was actually inspired by Giles, and I'm really going to report on a joint paper that we wrote. I presented a lot of this at PGDIS a couple of months ago, but Giles did ask me if I would put a little bit more in terms of the concept of trust into it. So hence the title. Now, we've heard a little bit about AI already in the previous talk. And here we often see papers like this appearing, revolutionizing healthcare and the role of AI in clinical practice. And when we get to our own field, many of you will recognize this very familiar face. How do we implement it into what we do in the world of assisted reproduction? And one of the things that keeps coming back and back is that AI must inspire trust, and it must integrate seamlessly into workflows. And when it does that, it might deliver some real benefits, ensuring that embryologists remain central, but nonetheless, they are assisted by AI. So the factors that affect trust in AI are as follows. Are they explainable? Are they transparent? Are they interpretable? Are they usable? And can they facilitate our own education? Because taking a line from this particular paper here, then one of the things that we can say is that there is a need to better evaluate and incorporate other critical factors to promote trust by consulting medical professionals when developing AI systems for clinical decision-making and diagnostic support. And it's this T word, trust, that is going to keep coming back again and again in my particular talk today. So this was the study. It was published in RBMO just a couple of months ago. You'll see that Giles was the first author. Here are the other co-authors, and I should remember, although this talk isn't sponsored by IVF 2.0, it is using technology that that was developed by them. And if you'll just excuse the pun there, a number of people have decided that they would quite like to use it. So ChatPGT is certainly free to use. This gives you a little bit of an overview. I'm going to talk a little bit about the background to the study, a little bit about AI, a little bit about embryo morphology and chromosome abnormality. I'll mention ERICA, what it is, some of the hypotheses that we tested. I'll talk about the results. The discussion will have these factors in it, and then we'll conclude with a few acknowledgements. So let's think of the first of these. We know that our field has undergone many, many innovations. PGTA is often the top of my list because it's something that I work on, but things like culture media and equipment, vitrification. But then equally, other aspects remain remarkably unchanged. And one of those things is the embryologist's subjective judgment. By and large, an embryologist, skilled as they are, will start looking at an embryo and say, look, in my subjective opinion, that one is more likely to develop into a child, or another one might not to be. Now, we know that there are different classifications that have been proposed over the years, not necessarily with a uniform consensus how to grade blastocysts. We know about the Gardner system, but then what happens to the fate of the poor quality embryos? Well, that depends on the local SOPs, on the single embryo transfer policies, and on the chances of survival and the likelihood of aneuploidy. So low chances of survival and likelihood of aneuploidy are the most commonly cited reasons for not transferring the low-scoring embryos, although we know that sometimes low-quality embryos, at least by morphology, can lead to viable offspring. AI can be used on static pictures, it can be used on time-lapse, and it can identify embryos most likely to implant. I'm going to talk about Erica today. Another example would be care maps. We know that AI is reliable and it's reproducible, but only within its own defined parameters. And we heard from the previous talk what some of those drawbacks might be. Equally, a human embryologist can be more subjective, can be biased, and of course, it goes without saying that embryologists might disagree with one another. AI can learn, and it can analyze complex patterns in much higher resolution with a lot more variables in mind. Now, when we turn our attention to aneuploidy, we know that aneuploid embryos, this is fully aneuploid embryos, so if we get 5 out of 5 cells, all of which are aneuploid, leaving out mosaics for a moment, we know that they rarely result in live births. So some AI algorithms have been trained against euploidy stroke aneuploidy as their ground truth. So the question that we want to ask ourselves is, how different is a blastocyst selection between embryologists and AI? How often will the AI choose a different blastocyst, particularly when the embryologists can't always agree, even amongst themselves? There are currently few standards, perhaps not no standards, but certainly few standards for choosing AI systems for embryo evaluation. And some of the things that depend on the type and size of the data set, on the output queries that we're testing, and the specific time point for image analysis. So turning our attention then to embryo quality and chromosome abnormality, we know that increased temperature and O2 tension can affect skeletal organization. It can cause spindle damage, and if we have spindle damage, we subsequently have chromosomal errors. We know that morphokinetic features are altered in aneuploid embryos. For instance, things like time to reach 8 cells, time to blastylation, time to achieve an expanded blastocyst may be related to aneuploidy. So there is a prognostic potential there in those features, and things like degree of fragmentation, multinucleation until the 4-cell stage, or the frequency of the embryo contractions. And I'd refer you to an article by Tom Bamford, a review of this in 2022, if you want to learn a little bit more about it. Now, of course, if we want to know what aneuploidy we have in our embryos, the most objective way to assess for that is by PGTA. But equally, PGTA is invasive. It has a high cost associated with it, and there are these concerns about mosaicism. If we have time-lapse imaging with morphokinetic evaluation or morphology assessment from static images and AI systems, we can use those to compare PGTA outcomes against findings. Now, it still is difficult, however, to find studies that present AI systems for embryo ranking trained against ploidy status as a ground truth. There's not a lot of that out there at the moment. Some studies suggest that AI models can outperform embryologists in predicting embryo quality and outcome. We know that it's got a great potential to enhance the reliability of the embryo selection, but nonetheless, further research and validation is necessary before we can implement it for embryo selection and for clinical practice. So, what's ERICA? Well, ERICA is marketed by IVF 2.0. It stands for Embryo Ranking Intelligent Classification Algorithm, and it specifically ranks embryos based on their ability to predict euploidy and also on the pregnancy test results. It uses static images. So in this case, time-lapse isn't used. And it has been shown to have some association with predicting the chances of spontaneous abortion. But to tell you a little bit about this study, what we did was we were using ERICA as a training tool. And in this case, we managed to recruit 19 embryologists. 6 of them were junior, 6 of them described themselves as intermediate, and 7 described themselves as experienced. And we had a sort of sliding scale for that, and we lumped them into certain categories to get consistency. And what we invited them to do was to say, is this embryo, by looking at the static image, aneuploid or euploid? Then we said, okay, that's what you think. This is what ERICA thinks. Then, armed with both pieces of information, we asked them to make a final judgment about whether the embryo was aneuploid. So these were our hypotheses. The first was that embryologists can differentiate euploid from aneuploid embryos significantly better than random. The second hypothesis was experienced human judgment augmented by AI, in this case ERICA, is a superior approach compared to either alone. And then the third hypothesis was that ERICA is more effective than, or at least as good as, experienced embryologists for predicting euploidy in these human embryos. And basically the way that this worked was we had a little game. It was an app just on your iPhone there. And every day you could download five cases that had 2 to 5 blastocyst images in them. Only 5 cases a day to minimize operator fatigue, but with the opportunity to perform up to 150 cases in total. So at 5 cases a day, 30 individual days. If you did it every day, you can complete it in a month. We had to then select what we think was the best embryo from the available cohort, even if the embryos were of fair or medium quality. Sometimes they were, and sometimes they weren't. And this is how it worked. Log on to your phone. What do you think is the best embryo? Drag and drop what you think the best embryo is. So why don't you have a go? And then, can you pick the poorest? Drag and drop it. And then the best from the final 3, the poorest from the final 2, and then this was the order that, in this case, I put them in. I thought that looked the nicest. Now, I have to say, I am not an embryologist whatsoever. But then we pressed the rank with ERICA button, and what it gave us was a classification. So here, I could say, right, okay, I thought that one looked all right, but you know what? I wasn't part of this study. I just had a go at it, and so I'm worse than the poorest embryologist. And ERICA also thought that this one was poor. It thought this one was fair, and the other 2 was poor. So 2 out of the 5 it agreed with me, but not for the first one. So I selected one in particular, and in this case, I got it right. So I got a well done. The embryo is indeed aneuploid. And 2/3 of the players selected this embryo as their first option. So I did all right. And if we look back at which one, given that ERICA said the first one was poor, but the second one was fair, I went ultimately for the second one in this case, and there it is. So what did we find? Or what did we look for? So the first outcome measure was the mean number of attempts to select a euploid embryo by the user alone without ERICA's assistance. The second was the proportion of euploid embryos selected at the first try alone without ERICA's assistance. And then finally, in this case, the rate of opinion change. So the proportion of cycles when, once we got the ERICA's assessment, the embryo is transferred embryo that they did not originally select as their first choice. And then, of course, you can have selections for the better or selections for the worst. So of all the people that did it, our 19 people, we only selected out the ones that had done at least 20 cycles. So more than 19 people started it, but only 19 finished it. And they could, as I said, go up to 150. Now, both we found, embryologist and Erica, identify aneuploidy significantly better than random. Erica, however, chose a euploid embryo on the first attempt, better than the embryologist, but embryologist's judgment, augmented by Erica, was not significantly a superior approach compared to either alone. Now, because of time constraints, I'm not going to show you all the graphs, but they appear in the paper. So going to our discussion then, our results have implications on how embryos are selected, on the impact that AI scoring has on the decision-making process, and on the trust inferred by that automated process. Now, of course, clinical embryology is relatively unique. At the moment, it has limited automation, relying heavily on manual dexterity and teamwork and subjective judgment. But those of you who are embryologists will know that your role is becoming more complex. You've got increased admin duties. You've got different forms of cryopreservation. You might be asked to do embryo biopsies more and more. Some of the confounding factors are the fact that these morphogenetic annotations that we trained Erica on are, of course, assigned by humans in the first place. So they are subjective, or they can be. Most studies in the past have been performed on retrospective data under experimental settings. And if we're going to apply AI, we still need to require some prospective investigations because there might be secondary factors such as lab conditions, other human factors that are not included in the models. If we're going to integrate AI into the clinic, then that may be slowed by the lack of RCTs thus far, because the clinics will want to pay the cost benefits. Again, getting down to this idea of lack of trust. It may be that one of the things that drives the integration of AI isn't that people think that it's better, but it might be driven by efficiency. So that might make it a little bit more palatable alongside trust, which I'll get to in a moment. How might these AI predictions influence decision making? Well, this particular study set out to address it with a game-like scenario. So in this case, it deduced how AI influenced embryo selection choice. And by using as a training exercise, what it did was familiarize the operator with the software used in the clinical setting. So it educated the embryologist to this dilemma of choice. And this was one of the things that we thought that engendered trust. By just getting someone out of the clinical setting to play the game, it might be that they might be trusting in it more. Will embryologists trust this? Well, this is another study by Giles. He, in his survey-based study, he suggested that nearly 94% of embryos are well informed about AI in the workplace, recognizing its limitations and being open to adoption. Tools that support decision-making could provide valuable assistance. Most embryologists view that the use of AI is going to be inevitable and expressed a willingness to incorporate it into the selection of gametes. But a smaller proportion, less than 60%, think it should be integrated into routine lab procedures. But 73% are open to adopting it in the near future. Contrast that, if you will, with the only 5% of respondents that were extremely confident of using it now, because they said we have a need for more training and experience. So again, this idea of a gamification may be a way to increase the uptake, to increase familiarity, and ultimately trust of these AI tools. So trust is a key factor if it's going to have widespread use and adoption in IVF. It aligns with the idea of democratizing IVF, so if you can make it quicker, if you can make it more useful and more consistent, and potentially, and certainly one of the things that I found that I just tried to put myself, I'm not an embryologist, but I tried to put myself into the shoes of one. One of the things that I found was it just made the process a lot more quick. There are embryos selected, right? Do you agree or don't you agree? So the lack of trust in the AI output, balanced with the embryologist's experience, introduces challenges, and it introduces barriers to adoption and implementation. But nonetheless, the strategies outlined here helps us manage that uncertainty. We know that this uncertainty is shaped by human factors, user educations, biases, perceptions, and the system's characteristics. So is it easier to use? And again, by using this gamification, it can overcome some of those problems. But one of those things that is key to trust is reliability. It must be reliable, it must be consistent, and it must be predictable. So in conclusion, AI stimulation could play a valuable role in embryology, similar to in the way it has been used in other fields like surgery, by recreating real-life scenarios that can be endlessly repeated and refined. An embryologist can then enhance their skill development without replacing their human expertise, so they can use it as a tool and a guide. It provides a controlled environment so operators can practice and improve. Now, humans will improve, but AI also will improve with the greater exposure to more data. So AI needs to function as a co-pilot alongside human expertise, and thus trust is engendered. It's almost like a mutual trust between the AI and the operator. Combining AI and human intervention does have the potential to be effective and popular, even though it was the case in this particular study that it didn't particularly improve selection. But what it can do is to cut down on overthinking, encourage strategies for self-reflection. And just on that note, this was my self-reflection of doing it as a non-embryologist. Engendering trust. Did I trust it any further? Well, it is hard to quantify that. You could do a questionnaire. Do you trust it more? Do you not? On a scale of 1 to 5. I have to say it was enjoyable. I looked forward to the 5 minutes in my day when I just had to play with that. It was nice to know that you were still in control. So the final decision was still yours. You were just aided by this co-pilot. I felt it made the process a lot quicker. I was click, 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 click. Right, this is what I think. This is what Erica thinks. I can now make a decision based on those 2 pieces of evidence. I think I would have agonized a lot more if it was just me transferring. It was good to have this electronic buddy. It was good to have someone, if you like, computer holding your hand. And it also gave a completely different perspective and a pause for second thought. So that's pretty much all I want to say. Just to say that as of this week, if anybody is interested, I have now set up my own consultancy in these particular areas. So if you want to drop me an email, please do. And that just leaves me to thank the people that were involved in this particular study, particularly Giles, the project lead, and Alejandro, who's one of the founders of IVF 2.0. And with that, I shall stop. Thank you very much.
Thank you, Darren. That was really interesting. It was a great talk. Yeah, it's certainly a lot to think about. And I think the trust element is just so important when you're introducing new technology. So I found it a really interesting talk. So we have a question in that obviously you spoke a lot about trust and trust between the operator and the embryologist and the clinic in using the technology. Where do you think the patient communication comes into that and the involvement of the patient when you are introducing the element of AI into their treatment? And how do you think clinics can maybe integrate that?
Yeah, I mean, the short answer is that I don't know enough about the day-to-day workings of an IVF lab, but I certainly could imagine a scenario where someone who was, because it's not necessarily the embryologist who is talking to the patient. But I could imagine that informed by the embryologist and the computer, a clinician or a counselor talking to a patient and say, well, look, these were the pictures. And, we had both our experienced embryologist and our computer working on this. And this is what we found. And this is how we came to our decision. So I felt that it would, and this is purely a personal opinion, but I felt that it was a lot more power to the elbow of the person who is the frontline explaining to the patient about why it is the case that this particular embryo was chosen, that you've done everything that you possibly can, having, if you just sort of say, well, our embryologist who's really experienced thought that was the pretty one, then fine. And that's, what embryologists do, they're very, very experienced in that and very good at it. But I don't know. It just seemed to me that to have that extra little bit of information to say we've done a bit of both, but this was a decision-making process. We were still empowered by it. It wasn't a computer says no type of scenario, but we were helped by it. I thought that, in the modern world, that's what we all do. When we write papers, everyone uses the word processor these days. We don't, we don't handwrite anything. We all, we use computers in our everyday life as our assistants. And so it struck a chord with me that it would be better as a patient-facing type scenario.
Yeah. That's great. We'll obviously have some more questions at the end, so we'll come back to that probably later on in the talk. But thank you so much for your talk, and it was really interesting. So I'd like to introduce our next speaker. And so please welcome Dr. Gary Harton, who is a founder and principal consultant at Grow Consulting Fertility and Genetics, and co-founder and chief science officer at Nova Genomics. Gary has spent over 30 years in the PGT field and IVF. He is certified by the ABB in molecular diagnostics and is a member of ASRM, ESHRE, and PGDIS. Dr. Harton is currently the chair of the PGT Special Interest Group for ASRM, a past board member for PGDIS, a past chair ESHRE PGD Consortium, and he currently holds teaching positions at Bryant University and Assumption University. So his talk is going to be kindly sponsored by Nova Genomics.
Thank you very much, Charissa. Does those slides look okay?
Yes, they look great.
Excellent. Thank you very much. Darren, I have to say I was struck during the end of Darren's talk there talking about trust and algorithms. And it strikes me that in my talk, I'm going to use the word algorithm, but nowhere really do I talk until the very, very end about artificial intelligence. And I think one of the things that would engender more trust from those of us, including myself, that work with and for AI companies would be to start clarifying technology names, right? What is machine learning versus AI? Is an algorithm AI? Does every algorithm include AI or does it not? Is that a marketing tool? I think we need to be a little clear about that, right? So here I'm going to talk about
Gary,
embryos.
Sorry to interrupt you. You haven't started sharing your slides yet, have you? The next slide.
I have.
Ah, okay. We're just still on the front slide at the minute.
Oh no, I haven't moved the slides yet.
Oh, that's okay. That's fine.
Yeah.
Sorry. Okay, perfect.
Like that.
Yes, lovely. Right? Just to check it.
Okay.
Wonderful.
Sorry. Yeah. Thank you for interrupting. I appreciate that. No, I appreciate that. We were having technical difficulties earlier. So there's my disclosures. And I want to thank my business partner at Nova Genomics, Cynthia Hudson, for agreeing to this without really asking and then telling me I was doing the talk. So Cynthia, thanks. Much appreciated. But today, really, we're going to talk about PGTA, really. A little bit of theory, some data, evolution of platforms. I took out the stuff on FISH and the array because in the end, that's really a while ago, right? I'm really going to focus on what's going on today and perhaps future directions and where I think perhaps we should be going and perhaps why I've gone in and decided to do a PGT lab. So I think, everybody that's in this field, I think everyone at this webinar has seen this chart. This is from the US CDC SART, just a chance of any woman in the United States getting pregnant, staying pregnant, or having a live birth. The hypothesis of PGT is pretty simple. If we agree that we all create lots of large numbers of aneuploid embryos, and those embryos are never destined to become normal live birth, Darren mentioned it a moment ago, then screening for aneuploidy in all chromosomes before embryo transfer during IVF should improve outcomes, right? That's a pretty simple hypothesis. And so that hypothesis came about some time ago. And we've been working in PGT for quite some time. And I've done this slide, and others have had the similar slide. But it really, for me, breaks down, for me, the intersection of where we are today as PGT, which is we started back in the early 1990s with fish for gender and multicolor fish with just a couple of chromosomes. And in the end, that was the best we had, and it worked okay, but not great. And then, 2000s, some people started messing around or playing with metaphase CGH, which gave us a whole new look at the genome and really opened up our eyes to what really goes on in embryos. Unfortunately, metaphase CGH is really, really difficult to do. Technically, it's technically challenging, and it's really difficult to analyze. And so then, through the late 2000s, late 2008, 2009, the array CGH came out from Blue Gnome. Soon around the same time, a couple of groups started messing around or started developing qPCRs or amplification, but directed amplification methods. Most of the PGT we had done in second generation had been whole genome amplified DNA followed by some sort of downstream analysis. Anybody that did qPCR or any of the directed amplification methods still have to amplify DNA. 4 to 6 cells from an embryo is still not enough DNA to do any molecular biology with. So please understand, anyone that does PGT-A, as far as I can tell, has to do some sort of amplification along the way. Some of those people target what they're going to look at. Others don't target what they're going to look at. But that sort of encompasses second generation PGT. And then really came third generation PGT, which was next generation sequencing, right? In the end, it's similar algorithms, it's similar technology, but the analysis tool went from a static look of a chosen set of pieces of DNA that we're going to look at on the array to, in theory, on next gen sequencing, one can theoretically see any piece of DNA from inside that embryo. And that opens up then some more possibilities and some more ideas. But notice, for me, one of the things that concerns me today is, notice when third generation PGT started. 2014 is when I put it. That's a long time ago in genetics world, right? It's a really long time ago in genomics and genetics world today. And so I think that where we are with next gen today and what it does, or where we are today with targeted, does what it does. And perhaps there's more that we could do, right? So I don't know, again, that I need to convince anybody that PGT-A works. Darren mentioned it. I mentioned the hypothesis. For me, this is the best paper that points this out. I have nothing to do with this paper. This is the Teagues et al. RMA non-selection study. And the idea here is you biopsy every embryo. The embryologist, without any other intervention, chooses the embryo to transfer. And once that patient is either pregnant or not pregnant, then we unlock whether we transferred an aneuploid or euploid embryo. And I think that's how it works. That's my understanding. And so you see here that when we unlock and transfer a euploid embryo, had a very good positive beta rate, 81% implantation rate, 69.2% had a fetal heartbeat and sac at 12 plus weeks. That's a really good implantation rate. And then a 64.9% delivery rate, which is, again, pretty amazing. So that's live born. If, when we unlock, we look at the embryos transferred that were aneuploid, still had about half of those embryos compared to euploid, still 41.7% implanted. 20% lasted to 8, 10, 12 weeks, which, again, for me, with a wife who does clinical IVF nursing, just letting patients go to miscarriage without worrying about it isn't necessarily really good clinical care, if you ask me. That's my opinion. But then ultimately, if you unlock on the delivery rate, not one aneuploid embryo led to a normal live birth. Again, let me sink that in. It's a couple of hundred transfers. It's one clinic or one group of clinics. But for me, this is a really, really, really powerful way to look at whether your test does what you think it does, right? You can validate tests in your lab, but you need to validate tests clinically, and they've done that. This is unpublished data shared with me from Dave McCullough. This is a look at the CDC SART database from the United States. This is looking at a certain years, 2014 to 2017. Ultimately, this is 451,434 embryos transferred in that time frame, with the only filtering done. In other words, did you get a transfer? And if yes, did you do PGT or no? That led to 451,000 transfers being analyzed, 118,000 with PGT, 332,000 without PGT. Remember, everyone around the world, this is a U.S. Data collection organization and website. This is about 420 to 430 IVF centers all over the country putting in, theoretically, every single egg they retrieve in this time period. It would be hard, in my mind, to manipulate this, and I'm going to unlock this pretty quickly. It's not going to surprise you. It doesn't surprise me that no matter how you slice it, if you did a biopsy and did some sort of PGT, you had a far better, this is live birth per embryo transferred, right? Now, you still have to get to embryo transfer. In this work, there is looking at how many people don't get transfers, so understood, right? But that's the data. I'm going to stop there and move on to technology. So this is NGS. We take a bunch of embryos, we put them together to save cost and money. We use barcoding, and then we take that and we make small little pieces of DNA out of all those pieces of DNA from Mrs. Jones and Mrs. Smith from embryo 1 and 2 and 3, and they're all barcoded with special barcodes that tell us Mrs. Smith from Mrs. Jones and Mrs. Smith's embryos 1 and 2 from embryos 3 and 4, and same for Mrs. Jones' embryos 1, 2, 3, and 4. So all those barcodes are used to then sequence and catalog which of these sequences belongs where. Each of those sets is then aligned to a reference sequence, the human genome, and then it's counted. Essentially, we take every single piece of DNA that we saw, we place it in the genome if we can be sure that's where it belongs, and then we cut the genome into 1 million base size pieces. And from every 1 million bases, we average how many times did we see counts from that piece of chromosome. And then, of course, by doing next-gen sequencing and whole genome amplification, you're looking at hundreds of thousands of sequences across every single chromosome. So all those bins are then, all those counts and all those bins are then pinned down to being one point on the algorithm. The algorithm says this is how many copies of DNA we think is there. And then that's compared to what we think is a human genome, a normal human genome. In this case, it was a number of individual males, all used whole cell, single cell amplification. So 50 single genomes, 50 times from 50 males, all evened out and assigned to this is what a euploid sample should look like. And then, of course, if there's any extra counts from any one chromosome, the system, the algorithm, can very quickly pull that out and tell you that you've got a trisomy 22 in this instance. So that's, in a nutshell, how NGS works. And that's how NGS has been working since 2014 on the algorithm that's really been written and begun really 4 or 5 years before that. Now, if we change gears and think about single nucleotide polymorphism, or SNPs, right? SNPs are, in the end, just areas in the genome where we have one base or another. We don't really know why they're all there, but for some reason they're all there. And it turns out that if you can do a little bit of SNP calling up and down every chromosome, you can begin very quickly. If you notice this one just with 6 SNPs on each chromosome, I can not only tell dad's left chromosome from dad's right chromosome, red and blue, but I can also tell mom's yellow and green chromosomes apart, and I can tell all 4 of those chromosomes apart simply with 6 SNPs. So imagine the power when you start putting hundreds of SNPs or thousands of SNPs or hundreds of thousands of SNPs to work when analyzing embryos and DNA. So when looking at SNPs, you can do a couple of different kinds of analysis. You can look at the frequency of the calls. In other words, in any one person, there should be some calls. Some number of SNPs should be BB, some should be AA, and some should be AB. If you start getting extra genomes in there, AAA, you can't really tell from BBB, but we can sure tell ABB from AAB. Now we can tell that we maybe have a trisomy on a chromosome. But with the power of SNPs, we can also notice we've now lost heterozygosity, which it turns out is something that happens in humans. We have loss of heterozygosity. You can get the same chromosome from the same parent rather than different chromosomes from different parents. All those things are problems in embryos that we may not be looking at today, that utilizing SNP calling allows us to look at. The other thing that SNPs bring, again, I mentioned that if you look at any one chromosome, you'd be able to see the ABB calls versus the AAB calls, and begin to see that for any one chromosome to delineate a trisomy for any one chromosome. But if you saw that call across all the chromosomes, now you begin to start looking at embryos that are triploid, which is a massive benefit because C&V analysis by 2 independent operating systems estimating ploidy both using quantitative and qualitative data allows you to look at triploidy, which is the most common cause of miscarriage in reproduction, not just in human IVF. And it's something that most conventional PGT platforms have a very hard time delineating triploidy from euploidy. Not all the time, but in many cases. So it's a real advantage and a real power of utilizing SNPs. Also, by using SNPs, you can begin to use haplotyping, haploblocking. People are probably familiar with the term karyomapping. You can use software that begins to look at key SNPs, non-key SNPs from both mom and dad, and begin to tell you exactly for this amount of this place in the genome, how many SNPs do I have telling me that this chromosome is there versus how many SNPs do I have telling me that that chromosome is there. So when having a reference DNA set along with all of your embryos, it begins to give you the power again to look at loss of heterozygosity, begin to look at inherited things that come from mom and dad that we may want to be on the lookout for or not on the lookout for. It allows you to do global and universal PGTM on many embryos if you have enough SNPs across the genome to begin to think about doing that sort of level of analysis. Now, I want to change gears here and talk a little bit about next-gen sequencing. I just talked about the power of SNPs. SNPs are really powerful, but next-gen can be really powerful as well. Guess what? When you read a next-gen sequencing sequence, there's a lot of SNPs in there. So if your software knows where those SNPs are and knows how to go look for those SNPs, then it's very easy to go use SNP analysis along with other analysis when using next-gen sequencing. Now, thinking about next-gen sequencing, I just want to point out here that not every next-gen sequencing platform does sequencing the same exact way. It's perhaps something you want to think about when you ask your provider what sort of platform they provide, what sort of technology do they use. This is some work that just looks at the mapping rates between 75 base pair reads and 36 base pair reads, right? So mapping rate means if I have 100 pieces of DNA, I'd like to know where all 100 of those pieces of DNA go, right? But I'm not going to be able to know that because there's lots of repetitive DNA, systems make mistakes. So there's going to be some DNA that I can't place in the right place. So if I have 36 base pairs, I might only get 85% of my reads in the right place, meaning I'm missing 15% of the reads I could have been looking at, I missed. But if I did 75 base pair reads, or if I did 100 base pair reads, or 150 base pair reads, I'm now beginning to look at much bigger and longer pieces of the genome. So just saying I do next-gen sequencing is not enough. You need to understand what amplification, what sort of thing are you looking at, and how are you looking at it? What sort of level are you looking at? right? Higher mapping rates means higher resolution, higher throughput for run. Most embryos today are frozen after biopsy. There's no need to sacrifice read length for sequencing time. Early days, we sequenced shorter because we had to. The future of looking at embryos, and if you ask me, is looking at breadth and depth in the genome. Traditionally, we've looked at them individually, breadth for PGTA, depth for PGTM. Ideally, we'd like to start looking at the future, looking at more than that. This is some work from a group I used to work with, we used to work for and do some consulting for. It's BioScribe. This is a white paper you can go on and look at. I'm not going to belabor this one, but in the end, this is whole genome amplified DNA from 42 embryo biopsies, regular real embryos from our field. The green box is the ideal QC spot for deep sequencing of these reads. So after deep sequencing, about 600 million reads, downsampling to even everything out to about 450 million reads, you can begin to see the percentage of the gene, the entire gene that was covered, the percentage of the gene that was covered at 4x depth. In other words, we saw that same sequence at least 4 times, and then the average mean depth. Understanding that geneticists start thinking about calling a mutation without knowing the mutation's there from mom and dad at about 20x to 30x depth. Those are the numbers that you're going to see. So you can see that this group was able to return those kind of numbers from just one whole genome with a new technology that's out there. This is a paper hasn't been published yet. I'm going to just put it up there just to point out that there are a lot of CNVs in embryos that are important, and we might want to start thinking of looking at these. This group did an amazing job of going and looking at small gains and losses, and then going back and looking at mom and dad, and was it in mom and dad, and was it benign, likely benign, a variant of unknown significance, or was it pathogenic? And then this is some other work that's, again, not published yet. This is just some work that really blew my mind, some work I did, again, at BioScribe, looking at single sperm, looking at single nucleotide variation SNPs. These guys are looking at specific variants associated with autism spectrum disorder. But in the end, they're averaging about 380, give or take 120, per sperm detectable individual single nucleotide variants. So in other words, every single sperm is delivered with somewhere between 200 and 400 variants in it. About 90% of those variants are non-clonal, meaning they're new mutations capable of delivering a disease symptom. Now, the reality is that most of our genes, most of our DNA doesn't really do anything. So all those mutations are hitting things that aren't usually a problem, but that's still a lot of mutation. I'm going to get back to this slide as the end of my talk here to say that if you ask me, I believe that 2025 has to become the custom platform era. I think buying kits, relying on others to tell you what aneuploidy is, relying on others to tell a laboratory what is and isn't a good embryo, or what isn't a mutation or a variant, or how to call variants. I think we're beyond that now. I think we've talked about AI a lot. There's no reason we can't begin to really apply AI to big data sets of here's 100 embryos that were transferred that were euploid, 65 implanted. Tell me why these 35 are different. If we do enough of that, we're going to begin to be able to apply new thoughts to our PGT that allow for embryo fingerprinting to confirm gamete identity. It's the biggest problem in IVF, certainly in America. We need to be able to detect more complex aneuploidies that disrupt pregnancy, triploidies, other variants that we're not looking at today that are missed with current platforms. We need to start utilizing refined PGT algorithms, continual iteration on algorithms, including actionable data points like pregnancy outcomes, better inform decision-making during PGT and for patients and physicians, and then analysis of parent of origin for aneuploidy, because in the end, that can help in decision-making, donor egg, donor sperm, and those sorts of things. And so for me, I'll finish there, say thank you very much, and just suggest that I think this is a golden era of genetics and genomics. It's a golden era of ways to analyze DNA. And I hope and pray that my colleagues and my competitors all hear this call, that we can all be better, we can all get better, and we can all do that by working much better together than we can by fighting with each other. So if anybody wants to get better, wants to collaborate, wants to work better, wants to do better studies, and wants to find better ways to diagnose embryos, please give us a call.
Perfect. Thank you so much for that. Just a quick question for you. So obviously sort of the testing that we do at the moment, obviously, as you said, I think has areas for improvement for sure. But if you are a lab choosing a genetics lab for PGTA, what would you suggest are the key sort of questions or data that you should ask these sort of providers for to sort of determine which is the best?
Yeah, I think it's a great idea. And honestly, there's no best. I hate to tell everybody there is just no best, sadly. I think for me, the answer always comes down, Dani, to laboratories work well together. You have to collaborate, right? You have to find the one that works best for you. Ultimately, many laboratories here in America, most laboratories are selling the same thing, right? You're selling on service, but you're selling the same kits and platforms. So ultimately, the question you should be asking your provider is, what kit and platform do you use? What validation did you do? And then can I see the validation data? Like, what did you do to prove to yourself this works? What sort of accreditation do you have, right? I think those are important things. And then I think for me, the last part is, what sort of tools do you have that helps me get better at my job? What sort of QA, QC can you feed back to me, right? Because ultimately, I get lots of information about your embryologist in your lab that you may not have any idea about. I see biopsy from everybody, right? I see volume from everybody. I see tracings, and don't get me wrong, really good biopsy leads to really, really clean results on my end. Really bad biopsy leads to really poor results. All those things are quantifiable using AI and algorithms and machine learning. So I think, Dani, the answer is, for me, there's some tried and true questions you should be asking, which every lab should be able to answer like that. They should have a dossier that answers those questions right now, right? And they should also be thinking about, how can we help you make all of this better? We're collaborating together. I can't get better without you doing more patients, right? So for me, that's the simple answer.
Perfect. Well, thank you for that. Well, I'd like to thank obviously everybody for their talk so far. Now a bit of questions for our speakers. So let's have a little look and see what questions we have.
Yeah. I have a question for Ariel, if that's okay. So I was just wondering, what is the data that kind of feeds into it? Is it primarily based on like hormone levels for like the trigger timing? Is it hormone levels that you put in, or follicle count and sizes? And then follow on from that, really, is that how would that data be inputted? Is it kind of manually entered by the nursing team, or is it kind of pulled from an electronic medical record?
No, of course, the best way, yeah, you mentioned correctly. We will need, for example, for the trigger algorithm, we will need both the follicle, the stimulation data, including the blood test and the follicle, the ultrasound, the follow-up. And I think the way it should be, it will be from the EMRs. We have integration going on with EMRs, so we can just get the results directly, and because you can put them manually, but I think it's very inefficient. I don't think it will work, and I think it should be based on acquisition directly from the EMRs.
Yeah, no, I think so, and I think it's a huge challenge really in IVF at the moment, is that there's so many different programs and softwares, and trying to get them to talk to each other is needed really to make it efficient. Otherwise, the efficiency sort of gets lost, and errors can be introduced. Is it, just to clarify, is it the follicle count and the sizes that you use? And would you recommend, like, is there a way to reduce inter-operator variability in how to count the follicles or measure the sizes?
No, so yeah, so you need all of these. You need the follicle size, the number of them, of course, and all blood tests. it depends on the algorithms, but we need also some data on the women, like the age and so on. It's not very big data that you need usually. I didn't have time, so I didn't show that there is what we call feature importance when you have a machine learning algorithm. It's a black box, but it gives you also something that it's called feature importance, and you see there what is important. Although it's a black box, you get what the machine is looking at. What are the main parameters that the machine is using to give you the what it takes into account for the algorithm, and we built it. Yeah, that we it can work. It doesn't need many data to be practical, and then it's based on basic data like age, BMI, and of course the follow-up parameters of the stimulation. If you're dealing with trigger, if it's ovulation prediction, as I showed, it's the blood test. It can manage very well without the ultrasound follow-up, for example. But you will need to connect with the EMRs, and it's something that it's working already. I mean, and at the end, there are not so many EMRs, but there are, and really it's a challenge to build those connection or those integration between the algorithm and the acquisition of the data from the EMRs.
Absolutely, and it can be quite expensive as well to integrate all these softwares as well, which the clinic needs to do.
Yeah, it's a challenge. It's a challenge. It's one of the challenges of acquiring the data. It's one of the challenging always to keep talking between all these,
Absolutely.
Yeah.
Super.
Perfect. So I've got a question for Darren. So there's lots of different AI softwares available now for embryo selection. But I think probably one of the biggest challenges is really being able to validate to see if that AI is improving selection. And it was basically just sort of, do you have any advice on how clinics would compare the outcomes from one AI provider to another to sort of see, does it actually help our patients, sort of the speed at which our patients get pregnant with this sort of enhanced selection?
Yeah, it is very difficult. And, if you're waiting for your live birth outcomes, of course, that's a very long wait. And with the best will in the world, are you really going to get, I think there are about 5 or 6 on the market at the moment. Are you really going to get licenses for all of them, line them all up against one another, compare them, so I think a degree of choice is, personal choice is part of it, and usability and trust certainly come into that. I think the only thing you can realistically do that would be quick is to ask the question of how good it is in predicting an aneuploid embryo, because at least you would then have a fairly, leaving aside mosaicism for a moment, a fairly bright binary outcome that we know is associated with successive IVF or not. You remember Gary's graph, the very last one when he was putting the critique study. If you have a fully aneuploid embryo, you have a 0% chance of live birth, and I think that's the message that needs to come across. So if you want to train it against anything, I would do it against aneuploidy. I'm biased in that way, and then it comes down to what do you like using? What are your embryologists going to trust? What are they happier in using? And that will vary from clinic to clinic.
Perfect. No, thank you for that.
Notice there are a couple of questions in the chat, actually.
Yeah, let's have a little look. I did just have one other question I was going to say for Gary, which is why are PGT test labs develop? Sorry, this was a different one actually. Sorry. I was going to say how can we reduce errors for wrong selection by AI, sort of when it comes to our PGTA results?
Say that again.
So how can we, because one thing that you do sometimes see is the sort of the error in sort of the wrong selection. So in regards to the results, I believe it's sort of sometimes the results get mixed. So would AI be able to sort of spot sort of any errors or
Yeah,
things like
I mean,
that?
certainly, as I think as both Darren and Ariel have both pointed out today, right? Humans get tired, humans make mistakes, humans are in bad moods. There is no way that if we aim to automate every process we can in our laboratory to cut down on the mistakes that humans can make, right? So there is no doubt that AI and machine learning and everything that computers and big data can do will not only make IVF better and more efficient, it will help us in the PGT lab for sure, right? I mean, ultimately, there's going to be some data sets that we can learn and discern more data points about embryology, right? The way your embryos grow and divide by comparing yours to other people. And there's just got to be a million new things we can learn. So there's no way that AI won't make everything better. Witnessing, right? Mistakes get made when people don't use witnessing, right? Take pictures of everything. All those things are incorporated in really good laboratories, right? We just talked about EMR integration and people writing down numbers, right? Or people looking at a chart. If I have my lab looking at a chart to do PGT and then having to write down the result on a piece of paper, type it in somewhere else, I'm potential for mistake there. AI can fix all that. AI can automate that. And I think that's critical for the future. And it allows humans to do human thinking, really great things, and computers to do really dumb, routine, rote things that computers do well that we don't.
That's perfect. And I also think the point about the witnessing is really interesting, because I remember when it sort of was kind of more just coming in, like, and you would go to clinics where they didn't use the witnessing, sort of electronic witnessing systems, and you just think, oh my goodness, like I couldn't even comprehend not using them now. So I think there will be a period of sort of adjustment and sort of adoption of AI, but I think we will look back in a few years and be like, oh my God, how did we ever work without it?
I think you're right, Ariel. I think Ariel had a quote at the very beginning, which is, you want your technology to disappear into the fabric of life, right? Xerox would be a good example. That's why it's a Xerox guy, right? Xerox is it's a common term for copying, right? It's just integrated in our world. So yeah, that's exactly. So the reality is that, again, I mentioned we've been using algorithms in PGT for the last 20 years, right? But nobody really talks about our algorithms as AI because we're not making them learn, but we could, we can, we should. Some people have been. That's important, and we need to move that way. Again, it's about unstoppable change here today.
Yeah. Just while we're talking about AI and kind of using it, I'm just wondering your opinion really on practical implementation when you're using AI to select the embryo for transfer. Like, a lot of them are marketed as decision support tools, and I guess AI in general. You make the decision based on the information that's in front of you, whether that be the grade of the embryo, and in addition with the AI score. And I'm just wondering what you think. Like, should embryologists be overruling the AI score for transfer, for choosing an embryo, and based on what we feel that's a better grade, regardless of what AI said? Or does that complicate really how we validate AI and see its true impact? And I just feel those two are kind of hard to. That's where the trust comes in. I feel that if I don't trust it enough, I'm going to overrule it, and then I feel like it's hard to get the validation of that data then to then trust it. So I just wonder what your thoughts are.
Yeah, I think that it's almost like a mutual thing. It's almost like training your dog. Your dog trains you as much as you train it, in many ways. And I do genuinely believe that ultimately the final choice, someone has to be empowered by it, because if you then start saying, oh, the computer chose it, nothing to do with me, you start absolving your own responsibilities. And I think that takes us down a very different road, even if the AI would be more accurate ultimately. If the AI is more accurate, then you can review those things and say, well, look, on X number of occasions we think the AI got it right, and the X number of occasions we think you got it right. and so on. And you can measure those over time. And I think if we took the responsibility and the agency away from embryologists, I think we start disempowering them, and I think we go down a road to perdition, really. And I wouldn't want to see that.
Yeah, it's just difficult because the embryos that you're freezing are all good quality blastocysts. So in your head, they're all suitable for transfer. And then you're using AI to decide the best one for transfer. It's just very hard to get the clinical data and validate your choice or AI's choice from that, because they're all usable blasts. And even with the nicest graded embryo or the highest AI score, it may still not implant for other reasons or for related to the embryo. So I just feel like it's really hard to tease them apart. And that's a challenge I think all labs are facing.
Yeah. And I think I think it's a very good point. And I think just to follow up on that, I think the benefit actually won't necessarily be in who or what is best. It will be how do we improve the workflow, and particularly Gary mentioned the witnessing and things like that. I think we'll ultimately see the benefits of it being more in that area than obsessing over, have we got a 1% better choice rate of AI over embryologists or vice versa.
May I, although it's embryology, but we introduced the AI. I mean, we use the iDoscope, but we introduced it in our lab about several months ago. And it's very interesting to see the process of the embryologist accepting. At the beginning, they were very, I don't know, I wouldn't say reluctant, but they were very hesitating using the AI. But as time is going, there are more and more seeing the advantages, and they discuss each cases while AI is one of the discussion. I mean, there are several embryologists, and when they don't agree with the AI, they discuss it. And more I see that they are really relying more and more on the AI. So it's interesting to see the adoption of this system. It's a tool support, decision support, but you see that it's coming, and you have more and more confidence in what the AI is suggesting you.
If you don't mind, I also wanted to add that, we have to also remember that AI is a really broad term for a lot of things, right? So ultimately, like, I think for me, what I think of AI is again, my little thing. If I have 100 embryos, I can guarantee you no more than 65 of them are going to implant. If I say that 100 euploid, right, today, theoretically, I think 65 is about what's going to implant. Meaning that if I could learn something actually actionable, right, I can ask an AI to tell me what's different about these 35 embryos, and then I can go start tracking those 35 things, right? And if I do that in 100 embryos or 1,000 embryos or 10,000 embryos, now all of a sudden I've got a couple of hundred things I can start looking for in embryos. Now I'm not black box wondering what I'm looking for. Now I'm using big data to help me see the pattern that I could never see myself. My team could never find that pattern. It would take us hundreds of experiments to find it. But yet we have tens of thousands of embryos in our hands, right? That is incredibly powerful information to help further what we should and shouldn't be looking at in embryos. What is and isn't important in embryos. What will and won't actually implant and lead to a live birth, because that's what's important. Not is my pregnancy rate better, is my platform better, right? But is can we work to find more things that we can do to better diagnose and find the best embryo to transfer right now, right? That's what we have to all be working on.
Yeah, very, very good point. I think that's probably a missed opportunity, in that there's lots of clinics using AI and not feeding that data back to anyone, and equally not really able to analyze that data very readily themselves. So there is loads of data out there, I guess, nowadays. It's just hard to capture it. For us, we've introduced AI for embryo selection, and I think that's, to your point, is that it's hugely improved the efficiency. So I think a lot of the time what the clinics will see first is the efficiency is improved a lot, whether that's needed to annotate or not annotate and use the AI score instead.
I have a bit more of like a general question kind of to the group, which is, what do you think are the most sort of promising scientific directions to sort of uncover the sort of still unseen variables, such as sort of epigenetics or uterine receptivity signals, that affect embryo viability, even when AI and PGTA predicts that it should be successful.
So what else can we look? I noticed that after being very quiet, endometrial receptivity has suddenly reared its ugly head again. So where I think, you know, there was something in that. I know that the randomized controlled trials weren't as successful as they might have been. There are always things that we can find. I think we have the whole world of transcriptomics, proteomics in terms of the embryo, but how does an endometrium receive something one day and not the other? How do the two things interplay with one another? I think we're going to be going down to the marginal gains, as we have in the world of IVF just in general. There are very few, out and out things that have changed things that radically. So my best guess is that we'll just keep finding things in images, in the transcriptomics and in the in the endometrium that will slowly get us to ultimately maybe in 20, 30 years time, one egg, one embryo, one baby. But we ain't there yet.
I have a question for Ariel. I was just wondering, it was just based on, I know we're talking about trigger times, but just going back to what you talked about when it came to frozen embryo transfers. And I'm just wondering, for clinics using like HRT programmed FETs, could your program help, or do you feel like it would encourage more natural cycle FETs? What way do you think it would help the most?
No, I think for the HRT, we don't have a lot of a contribution, but I still think that according at least to many data that is accumulating regarding the difference and the advantages of natural cycles. I personally moved after several years ago when all those data were appearing on the more complication, obstetrical complication during after HRT. I moved to natural cycle, and we have to deal with the weekends, with the closure dates and so on. And for that, it's very helpful. Because when you can predict ovulation in advance and you can schedule it and keep it natural cycle when you don't need the trigger and do the modified when you need it, I think this is an advantage that we can offer by the AI. I don't think that in HRT we have a big contribution.
Yeah, I guess
it's interesting also, just one more thing. We were looking at this, what should be the percentage to work with balance or to deal with things like that the clinic should have to balance all the cycles. So if you have about 30% of HRT, you would be able to balance very efficiently all your frozen embryo transfer, which is also important.
Yeah, it's a good point, and I'm sure with time more data will feed into that as well. Like, I don't know if you looked at endometrial lining or thickness, which we obsess about sometimes. If that outcome, the ultrasound input into that model would help with predicting outcomes or give us the best success timing for implantation.
I think that the endometrial thickness, of course, is a part of it because, there are all these methods coming in to deal again with the problem of scheduling, suggesting to trigger on 13 millimeters or follicles to give already the trigger, then you can advance it more efficiently and deal with all these weekends, or begin progesterone right early when you have an endometrium of 7 millimeters or so. But in those cases, I believe that if you advance too much the trigger in the modified natural cycle with the ATG, I'm afraid that the corpus luteum will not be optimal or the endometrial thickness will not be enough. If you understand what I mean.
Yeah, no, perfectly.
We've got a question here on the list for Gary. So there's a question here from Karima. Generally good morphology blastocysts by microscopic static assessment are analysed for PGTA, PNS, and the bad morphologies are excluded. So do you think that we should be giving it more attention to the bad morphology?
That's a really interesting question, honestly, and I think there's more layers to that, right? I think, it's a constant question for PGT-M patients, right? Patients that have monogenics, they want to know about every embryo is actually helpful for us, perhaps structural rearrangements as well. One of the other things I didn't mention it, but utilizing SNPs allows you to look at 0PN, 1PN, 3PN, and 2PN molecularly, not just by eye, right? Looking at it by eye with no time lapse and nothing else to aid you, you will miss the actual event some percentage of the time, right? Some percentage of the time, every embryologist misclassifies a 2PN embryo as a 0, 1, or 3, right? Or maybe it doesn't misclassify. Again, I'm not an embryologist, but certainly there's some number of embryos we don't biopsy. Now with newer technologies, you can biopsy all those embryos. Ariel pointed it out. Again, doesn't say MD after my name, but I've got a wife who's a nurse. I also know if you got one more egg per patient, if I had one more embryo per patient to look at or to analyze or to diagnose, that is better outcomes for people for sure, right? So if we can find ways to better biopsy those poor quality embryos, more ways to biopsy embryos that again are 0, 1, or 3PN that we don't do. I think every embryo gives us information. The more that we can biopsy and get that information, the more we'll know. Listen, if we could get a bunch of those really, really classically ugly, bad embryos, maybe there's something in there. Maybe there's some mark of genetics that we could find real quickly, right? And maybe that's an easy, non-invasive test of non-viable embryos. I don't know. I think there's a million things we could possibly learn, but if we don't test, every embryo we test gives us more information to put into our algorithms and more data. So yes, it may not be clinically actionable. We may not transfer those embryos, but we can learn. And I think at this point, I think it's very clear, learning more about genetics, genomics, and how embryology and IVF works will help us help patients better. Darren mentioned it, right? 30 years on. I started in this field a long time ago. This hair is very gray. I started here a long time ago, and pregnancy rates were in the teens across the world when I started, right? And they're not there now. And that's a testament to a lot of hard work by a lot of people. And we can be those people too, all of us. So yes, we should get a hold of everything we can. And again, work together, do research. That's important.
Perfect. Well, I think on that note, we're going to bring the session to a close. But I would just really, really like to thank sort of everybody who's taken part in this today. So firstly, our moderators, Dr. Carol Loscher and Charissa Watchorn. And of course, our presenters, Professor Ariel Hourvitz and Professor Darren Griffin. And of course, Dr. Gary Harton, and of course our sponsors as well, Fertile AI and Nova Genomics.
I've got to get a proper professor title. Apparently, I can't come back without a professor title now. But new my bingo card, guys. Thank you so much. It was really great having me. I really enjoyed doing that. Always great sharing a dais with Darren, even electronically, and Professor Hourvitz. I haven't met you yet, but I'd like to meet you someday. You seem really interesting to me.
Thank you.
Thanks very much for the team as well from I3, the organising committee. So they are Jack Cohen, Peter Nage, Mary Ann Cervantes, Thomas Elliott, Fran Farley, Violetta Sora, and Giles Palmer, of course. So thanks very much.
Perfect, guys. And just join us soon. We've got another i3 webinar coming. The next one installment is called Battle of the Banks, where global egg banks will battle it out. And this is sponsored by Future Fertility. Okay, so see you then. Bye.
Perfect. Take care. Bye.
Yeah.